afternoon, everybody, and welcome to our session. It's great to have you with us today. Today, we will be talking about what's going on the ground in Florida, one of the nation's largest healthcare markets. I'm Beth Kidder. I'm the managing principal at Health Management Associates and the former Medicaid director in Florida. We have a distinguished panel today with us with decades of experience in multiple aspects of healthcare. Let me introduce the panelists. Jennifer Sweet is the CEO of Aetna Better Health of Florida. Nathan Lansbaum is the plan president and CEO of Sunshine Health Florida, Centene affiliate. And Mary Mayhew, president and CEO of the Florida Hospital Association. We'll each be giving some brief remarks to introduce what is going on in Florida from our perspectives and what we're seeing, and then we'll be taking your questions from the audience. As you may know, by now you can put your questions in the Q&A box at any time during the presentation. So I will lead off and start with some context from my perspective. I would start by talking a little bit about managed care in Florida. Florida Medicaid has had a managed care system since about 2014. And that system brings in all the different aspects of care. So behavioral health is in, dental is in, and all the medical services and long-term services and supports. And so it is a fully managed care system for almost all enrollees. And with that push towards managed care, we also had a push towards more accountability for the system, more transparency, and focus on outcomes for the beneficiaries. What we have going on now, though, in Florida is the beginnings of the move towards reprocurement of the contracts, which will then be for another 6 years, and those will start in 2024. So there's a lot of focus right now within the industry, starting to think about what are the priorities for the next 6 years of the program. Also, the program is continuing to push for more accountability as well, and to keep moving forward on that. As we moved into managed care, we were able to start to do apples to apples comparison to other states and to benchmark against other state Medicaid programs using national standard measures like HEDIS measures. And we saw a lot of improvement in the first years of the program, the first decade of the program, whereas before we started statewide managed care, only about 40% of our measures were at or above the national average compared to other states. But after several years of managed care, we continued to see a steady increase, and now we have rates that are about 67% of the measures at or above the national average. So it's still a long way to go on that, but a lot of progress made. Now the challenge is to keep that progress going in a positive direction and to really start to dig into populations that might be left behind when you look just at data in the aggregate. And to that end, Florida is starting to look at outcomes by race and ethnicity. This past year was the first year that the health plans were reporting data broken out by race and ethnicity for a subset of measures. And there's a move in the Florida legislature that a bill that is moving forward right now that would further push the envelope on that kind of reporting. This bill would have measures stratified by age, by race and ethnicity, by gender, by primary language, and by whether a person has a disability. So that really will start to help see where there are populations that may need a more targeted intervention. And then the last thing I'll comment on, which is not just a Florida issue, but has a major impact in Florida, is the unwinding from the public health emergency, and particularly in the area of eligibility redetermination. As many of you know, as part of the public health emergency, Medicaid received additional federal matching funds to help with the surge in enrollment and the challenges around the pandemic. But with that came a requirement that eligibility not be terminated for anybody. And so the Medicaid rolls have grown considerably over the course of the pandemic, over 17% nationwide. In Florida, it's even more dramatic than that. The rolls have grown by 1.2 million enrollees, which is a 33% increase. So states are now facing the Herculean task of conducting redeterminations for millions of people, and many of whom have fallen out of the habit of responding to the state's requests for them to give them information for eligibility. This is at the same time that states and all markets are being hit by labor shortages that make it difficult to have enough eligibility workers to process the current workload. So this is something where I think all stakeholders who have any part and any piece of healthcare will need to be aware of this as this starts to happen, and to assist the state in outreach, in getting good information out to people on Medicaid as to what they need to do, and to really help make an all hands on deck push for people to respond to the state when their eligibility redetermination comes out. So those are just a couple of observations from my perspective. And with that, I'm going to turn it over to Jennifer Sweet to talk about it from the Aetna perspective.
Thank you, Beth. And thank you to State of Reform for including me here in the panel. It's a real honor. I'm Jennifer Sweet. I'm the CEO of Aetna Better Health of Florida, which is a Medicaid managed care plan in Florida. We are part of the bigger Aetna CVS enterprise. Many of you are aware of the ways CVS is developing the delivery of care in its existing retail and Minute Clinic Health Hub locations. Through this work, we're expanding access to care and creating a holistic member experience, addressing both clinical and social supports. Through the connected capabilities of CVS and Aetna, we're redefining the healthcare experience available to everyone in our communities. There's so much happening, and all of it is very exciting and transformational. But today, I'm focusing only on what we're doing in Florida, particularly with those activities that impact our Medicaid population. First thing I'm going to touch on is how we're expanding access to behavioral health. Then I'm going to talk about care-focused pilot programs that integrate CVS and Aetna assets. I have two community-focused initiatives I'll talk about. And to wrap it up, I'll highlight in Orlando an affordable housing project, which we're invested in. So let's look at the Minute Clinic and Health Hub brick and mortar locations first. In addition to enhancing PCP services there, we're bringing in behavioral health services. Specifically, in Florida, we're adding licensed clinical social workers to 5 pilot Minute Clinic locations in Tampa. Through these added services, individuals can receive private mental health assessments, counseling, personalized care plans, referrals to higher level of care as needed, and they can receive their care either in person in our clinics or through a video consultation. Very convenient option, very easy way for members to learn to navigate behavioral care, and we're also offering evening and weekend availability for appointments at all of these locations. In addition to preventive and behavioral care at the Minute Clinic and Health Hub locations, we also have a diabetes support care program, and in increasing locations, a diabetic retinal exam opportunity. CVS also offers a retail drug abuse support program. We have 58 stores that have full-time drug disposal units on site, and the Pharmacist Teach program, which currently has reached 55,000 students and parents around avoiding prescription drug abuse. We also connect the health plan to the CVS resources through the Bag Tag program. This is a program that allows us to communicate specifically and directly to our members when they're in the pharmacy picking up a prescription. The prescription bag messaging campaign includes health and wellness recommendations that promote condition management, advise on preventive services, or enhance their understanding of their health plan benefits. A member could get just the printed message on their bag tag, or if prompted, a pharmacist may engage in a conversation, verbally reinforcing the message on the bag tag. In addition, this may prompt a conversation with a Minute Clinic practitioner also on site. again, to reinforce the intervention that's suggested on the bag tag. In all cases, the bag tag messages have demonstrated delivery of recommended services and closure of care gaps that exceed those delivered to members who did not get the bag tag. So this is a very successful program so far. Pilots for Medicaid members. These are care programs that combine the pharmacy, Minute Clinic Health Hub resources, and the health plan care managers for a connected and coordinated experience to advance member health and well-being. First up, Pediatric Asthma. This is a shared risk program between CVS and our health plan that lays out retail interventions aimed at addressing asthma medication gaps, improving adherence, and providing education. Diabetes. We use analytics to identify and prioritize tailored interventions for our targeted members. The members are co-managed across select clinical areas that are designed to help improve A1C. We have a chronic kidney disease pilot. This is a data-driven care management program providing end-to-end care for members with chronic kidney disease, from early diagnosis and management to end-stage renal disease. We also have a readmission avoidance programs. This involves multiple interventions between the plan and CVS that proactively target those members with a recent hospital admission, all to address the preventable readmission, of course. I'd like to shift now to our community-focused initiatives. First, community resource centers. This is where we provide the spaces that connect members to care and community resources and to trusted providers, including PCPs and pharmacists. By partnering with an FQHC, for example, we bring together the strengths of the FQHC and CVS to leverage and promote new access points to the community. Some services will be located on site, while others may be delivered via referrals to primary care and specialty services. In addition, the CRC expands member access to telehealth by providing the technology infrastructure that might not otherwise be available to a member. We are selecting CRC locations after local analysis that includes a review of the community resources, the local provider network, and the Medicaid needs in that particular neighborhood. Right now, we're focusing on locations in Miami, Orlando, and Tampa. In addition to the development of the CRCs, we're putting considerable Florida focus on workforce initiatives. CVS has a long history of job training in Florida and in other states, starting here with an externship program in 1997. Nationally, we've transitioned about 120,000 persons from public assistance to a CVS career. Now, in Florida, we are proactively targeting more local communities with the establishment of workforce innovation talent centers, otherwise known as WITCs, much more convenient term. There are 5 existing WITCs in other states, and our plan is to bring a new one first to Orlando. At the WITC, we offer tailored education and training opportunities with the goal to create sustainable workforce. We deliver onboarding and training of new hires, as well as welcoming members of our communities for training engagement opportunities. Based on experience in other markets, we expect to impact over 13,000 people at this training and development center. Further, the center will typically offer daycare and health services on site. And finally, let me take a look at affordable housing, the real estate development that CVS is engaged in. Nationally, we have over $1 billion in affordable housing investments, 44 million of which is in Florida. I'd like to highlight one development in particular, the Fairlawn Village in Orlando. This site is in a neighborhood where 60% live below the poverty line. It's scheduled to open in May of this year, so we're very far along. There are 116 family units at Fairlawn Village, 20 of these are permanent support housing units, or PSHs, for people experiencing homelessness, survivors of domestic violence, persons with a disability, or youth aging out of foster care. We'll be providing on-site services, including adult literacy, employment assistance, financial management programs. The PSH units in particular will provide case management coordinated to our plan and other services by the co-developer, Community Assisted and Support Living, Inc., otherwise known as CASTLE. So I'd also like to add that a workforce initiatives program will be brought to the residents of Fair Lawn Village. So that's a recap of what we're doing from CVS and the Medicaid health plan here in Florida. Nathan, I think you're up next.
Yeah, thanks a lot, Jennifer. I really appreciate that. And I also want to thank State of Reform for allowing me to be here and inviting me and allowing me to share kind of what we're doing in the state of Florida. First off, let me do a little bit of an overview of Sunshine Health. Sunshine Health is a Medicaid managed healthcare company in the state of Florida. We are a wholly owned subsidiary of Centene Corporation. We've recently merged with the legacy Staywell, which is the WellCare managed healthcare company in the state of Florida. That official integration took place on October 1st of last year. So now on a combined basis, we are statewide, was before, still am. We've got roughly 1.5 million members in the Medicaid program. In addition, we've got a little over 300,000 in the marketplace product statewide, as well as 160,000 Medicare members. And on the Medicaid side, we've got numerous programs within the Medicaid space that include long-term care, the SMI program for seriously mentally ill. We operate the Children's Medical Services program on behalf of the Department of Health. And then we've got a sole source contract on the child welfare and have been doing that sole source contract for a good number of years at this point. That is dedicated to healthcare for children that are in and adopted out of the child welfare program in the state. I want to focus a little bit on the behavioral health side. I could kind of go a lot of different places with respect to where Florida is right now: value-based contracting, social determinants of health. There's a lot of things that we are focusing on in order to make sure that we bring the services that our members and our providers need to make sure that they are happy and healthy in everything that they do. But I do want to focus a little bit on the behavioral health side and then some technology before I end. We know that behavioral health impacts physical health, and the physical health impacts behavioral health. And if we're not addressing the behavioral health, we can't be successful. Integrating behavioral health into our overall care approach isn't a nice to do, it is a must do for improving health outcomes. We have teams of nurses and licensed mental health clinicians who work together to address both. On the behavioral health side, at the core of we've got a number of programs that are at the core of what we do. We offer mental health virtual visits through our partnership with Teladoc. We've got a 24-hour, 7-day-a-week behavioral health crisis line. We have expanded benefits that offer different therapeutic and educational options for members. And we don't just do that for members, we actually do that also for families and caregivers. A lot of what we offer is geared toward the entire family unit to make sure that all the support that we can provide the family is then wrapped around the member. For example, one expanded benefit focuses on family education after someone is newly diagnosed with a behavioral health condition, so that they can understand exactly what is going on with the diagnosis as well as the behaviors, so they kind of know what to expect and we can prepare them for what they have to deal with. It's also important to have behavioral health integrated at the provider level. We have behavioral health homes where primary care and behavioral health is co-located and operating with integrated care plans. And then we have primary care physicians that partner with behavioral health providers. So we make sure that both of those are connected, so both sides are addressed. Real quick on the technology side, technology really helps us help the members overcome social determinants of health, especially during the pandemic. We've got a community connections program that builds partnerships to support the social safety net. We use metrics from that program. We've got a helpline associated with that program, and we can use that to find gaps in services and form new partnerships based on need. We've got over 1,500, 1,600 care managers at Sunshine Health managing our members' needs. And last year, they made over 60,000 referrals to local organizations to help our members address the social determinants of health that they have that are barriers to their health care. We've awarded grants to over 50 organizations throughout the state to help from everything from food insecurity to rent and utility assistance. And then lastly, on digital member engagement, a key component to improving health outcomes continues to be finding ways to engage members where they're at. We want to reach members where they are. Many of us, that's often via the cell phone, their smartphone. So almost 95% of our members have access to a smartphone and use it on a regular basis. So emails and text are more efficient and more reliable than the traditional mail that we've used to provide information to our members. And then we've also got some unique care management models, such as digital smartphone access to a care manager, and that helps make sure that our members are able to access their care manager via their mobile technology. And it's a great way for us to engage our members. So we are always on the lookout for ways that we can innovatively engage our members to make sure that they engage with us and their healthcare needs, because the better they're engaged with us, the more likely it is they're going to engage with their provider and be adherent to the care plans that we've got for them to improve the outcomes. And with that, I will turn it over to Mary Mayhew.
Well, thank you. And as my co-panelists have said, it's a pleasure to be here. Beth, it's a pleasure to be with you. We haven't been able to be together for a while, so this is awesome. So let me, I'll do my best, and I'll do my best to try to sound positive, but I'm not very positive about where we are. And I think as much as we want a vision, we've got to be honest about where we are and to put in perspective. So we now, as Beth said, we have over 5 million Floridians, vulnerable Floridians, who are enrolled in the Medicaid program. That is more than the population of 6 states in the United States. So just think about the volume of individuals that we are trying to support. And again, our elderly, our disabled, the 45-year-old with Down syndrome, the 28-year-old with schizophrenia, the young mom with a baby. And of course, in Florida, when we talk about parents who are on Medicaid, they are at 31% or less of the federal poverty level. So when we talk about social determinants, while it is true across many economic stratas, it is absolutely fundamental as we talk about the parents and the families and the children that we're serving. And of course, part of the challenge that we face in Medicaid is that the social services are so critically important to help those improve those health outcomes. Yet the programs are siloed, from the SNAP program to the TANF program, to the unfortunate but potential interaction with child welfare, the housing vouchers. And what we know, none of this is rocket science, we need to be able to create that comprehensive approach that is both the integrated care with the social services that help to improve outcomes, sustained stability and improved outcomes. And, you know, we've had a great example of progress that's been achieved with the Medicare, you know, Medicaid and Medicare under the exact same large federal umbrella agency. And Medicare 20 years ago really pushing around public reporting and quality improvement and the advancement of key models of care focused on chronic disease management, the accountable care organizations, and all of the concepts and philosophy that we truly understand why those matter in improving outcomes. We have got to take a look at the opportunity to move in a very same direction in Medicaid. And my panelists have all articulated many of the models that matter, but I do want to dive in first to the preventable and the outcomes driven, and just again acknowledge in many ways we're still trying to get out of the system that has been so much a part of the healthcare system for so long, and that is the volume driven. We all know that we want to truly embrace a pay for performance, an alignment of incentives that helps to reward and incentivize the models of care that will create that comprehensive approach that allows for the consideration of the housing and the food and the employment and the enhanced stability that will lead to those improved health outcomes. Critically important that we're able to embrace and move in that direction. And the investment in prevention and primary care, and this, again, it's not anyone's fault, it's just we've got to get away from the crisis-oriented, facility-focused structure that Medicaid has had for decades. That is absolutely the case when we look at mental health and substance use disorder. It has led to a more fragmented system, individuals who are often in the revolving door of the emergency department, in and out of inpatient psychiatric admissions, and worse, county jails, homeless shelters. And those are the individuals who depend on us and are enrolled in the Medicaid program and need to be part of the approach that have been described here, but with a sense of urgency to look at where we can begin to move the needle. Moms with opioid use disorder, we know that early identification, great access to prenatal care, innovative models that are not only about the prenatal, but while they're in the hospital, and then the discharge plan and medication-assisted treatment. We've seen the results. We know what works, and we've got some great models. Memorial Hospital in Fort Lauderdale has been studying this for quite some time, collecting data regarding sustained improved outcomes. I think the challenge is often how do we take these outcomes and these models of care and start driving policy and payment. And certainly, as Beth described, we've come a long way in Florida with the introduction of Medicaid managed care. And it does take time for those systems to evolve and to mature. But as we look at the horizon and where we want to go, we've got to raise the bar. And as much as I appreciate exceeding some of the national averages, I'm somewhat disappointed with where some of those national averages are. I mean, one of the examples around integrated behavioral health, if you are on antipsychotic medications, we know that you are at higher risk of developing diabetes. So when we're paying for an integrated model, we want to verify that those individuals on antipsychotic medications are being regularly screened for diabetes. And the reality is often when we look at that data, that it's not happening. So it is both embracing that integration, paying for that integration, and then verifying that the integration is actually occurring and that we are monitoring both and supporting their behavioral health and their physical health, because we know the model works. It's just if you have been underfunded, if your reimbursement rates haven't kept pace with the cost of care, the models of care, sometimes when we move into these other models, we backfill the hole in our funding stream, but we don't necessarily move in the direction of that model. I think for hospitals, especially given what Medicare has been driving over the last 20 years, it's an acknowledgement that discharge of the patient is not where our responsibility ends. The entire focus on readmission rates has changed that focus for hospitals, and we've got to continue that work. And so in terms of the vulnerable populations in Medicaid, hospitals have been expanding their work into the community, probably perhaps not as aggressively as what we've seen in other states, but developing those partnerships with the FQHCs, with the mental health agencies. So you see in some areas of the state these broad regional coalitions that have come together, employers, mental health providers, local law enforcement, homeless shelters, hospitals, FQHCs, coming together to look at their the variety of roles that they all play that can support a family-centric, a person-centric approach to care. And again, I think it's important to acknowledge the federal funding streams, the federal program structures, the how do I say this as diplomatically as possible? We all respect the privacy and confidentiality of HIPAA, but sometimes there are interpretations that detract from a comprehensive approach to care that can produce far better outcomes for that individual and for that family. So we have some great models in Florida, in Tampa Bay, in the Jacksonville area, in Pensacola and Miami-Dade, where you do have these coalitions. What I would love to see with our Medicaid program is, and with our plans and with our hospitals, how do we draw from those regional collaboratives to understand the test, the research, the models that are truly starting to produce incredible outcomes? And how does that start to drive a standardization of practice around the state, inform policy, inform payment, so that we do aspire to not just exceed those national averages, but we start to be the leader of producing the best possible outcomes for now more than 5 million Floridians. The barriers are great. And when we talk about mental health and substance use disorder, I think often what happens, that it is so overwhelming, the magnitude of the challenge. Often mental health and mental health systems around the country have been driven by class action lawsuits. Not a great way to design systems, but often that is in fact what has occurred to hold feet to the fire. And then we move away from the crisis, from the class action lawsuit. And Medicaid is the dominant payer in mental health and substance use disorder. So looking at the research-based models of care, assertive community treatment teams is a fantastic example. We have them. They are underfunded. We don't have enough of them, but they are an evidence-based model when they adhere to the fidelity of the model that really is community-based and can reduce the expensive use of the emergency department, which is not in the best interest of that individual with serious and persistent mental illness. And we know individuals with serious and persistent mental illness or with schizophrenia, one of the biggest challenges is medication adherence. And the point of a assertive community treatment team are those wrap-around services. They are going into their homes, into their apartments. They're able to look at the environment, but also help to support that medication adherence that can improve their stability and reduce some of that preventable use of the system. So we know it works. We also know what barriers we are up against, but I am confident that we can move in this direction. I guess, Beth, I know we're running up against some of the time constraints, but let me just say, one of the areas, and Nathan raised this with technology. Well, I think hospitals have definitely invested in the data analytics and the opportunity to partner effectively with managed care plans to share data to drive expectations around performance. When we talk about primary care practices, particularly smaller practices, that is probably one of the bigger vulnerabilities and challenges is the data analytics. And we know that it's in that primary care setting that we have the greatest opportunity for improved health status, better chronic disease management, early intervention, focus on primary care. But being able to monitor your panel of patients and have real-time data, not 3-year-old claims data, but real-time access to clinical data that provides that view, that allows for those early interventions. That is an area that I think we collectively need to better understand. What do those investments in backroom offices or of shared services, support services, IT services that can help those primary care practices, those behavioral health, mental health agencies really support that real-time, client-centric, patient-centric approach to the work. And then all of us together continuing to bring social services into the mix to support that integrated, comprehensive approach to care. Beth, I'll close there to say I am optimistic that we have the shared commitment among all those, but there's when you beat your head up against a brick wall, sometimes people can have they can develop paralysis around the tackling of the issues and a frustration. But I am confident with so many of those that are involved in Florida's healthcare system, from the plans to the providers to the state agency. There is a shared focus on moving the system continually forward in the best interest of those who depend on it. So I look forward to our innovation and our commitment to improve health status.
Well, thank you all, Mary and Nate and Jennifer, for getting that going. Before we launch into just some more commentary in response to that, let me let the audience know that you can put questions for us in the Q&A. There are also a couple of polls that are open on the next tab next to Q&A that you can answer, and sort of based on what we see there, that might lead our conversation a little bit, asking what you think the priorities should be in healthcare in Florida, as well as what you think the legislature is doing with healthcare and how well you think they're addressing our issues. So many things to start with here. It's hard to know where to start. A couple themes I took away from all of you. I think almost everybody addressed behavioral health at some level. And that's relatively new. I would say in the last 5 or so years, really come to the forefront, is understanding the impact on health. We can talk about workforce shortages. We can talk about technology and telehealth. We can talk about value-based purchasing. So jump in, folks, if you want to comment on anything anybody said in this in the first round here.
Well, I mean, I'll start on telehealth, and I think Nathan might have mentioned this as well. It is interesting for how long we tried to increase the access to and the use of telehealth. And Beth, you and I were studying the data very early on in the early stages of the pandemic. And like that, literally in a matter of 30 to 60 days, overnight, skyrocketing availability of and comfort in and use of, both by providers and consumers. And I think, again, in the glass half full, that is what we have to really look at and understand, that there is positive disruption that we need to think about and be able to capitalize on, and we want to sustain it appropriately. It should not be replacing all in person. We want to make sure that the quality of it is where we need it to be. But when you think about Medicaid, and I don't want anyone to lose sight of this, one of the biggest barriers in Medicaid to timely access to care in the right location is transportation. And telehealth is that bridge. Again, it is not to replace all, but when we think about behavioral health, again, mental health in particular, that is a lifeline right now for anyone, whether you are Medicaid, commercial, et cetera. It is difficult to timely get in to a mental health practice. And when you are ready for therapy, if you have a substance use disorder and you are ready for treatment, the door needs to be immediately open. And that is where I think telehealth can be such an immediate access point. And when we think about teenagers, they love it, right? That's what they're used to. My gosh, I always say to my kids, can't seem to answer the phone when I call, but you can text. So we need to understand generationally, and our kids, the last 24 months, we know that we've seen over many years an increase in anxiety and depression among our teenagers, only just now exacerbated by the isolation and the disruption in their lives over the last 24 months. So I think knowing how we can best leverage that technology to support that timely access will be critical.
Yeah, Nate or Jennifer, you want to comment on telehealth?
I'd say it's one of the things that has been a good byproduct of the pandemic. I mean, if you can point to any, the no-show rates that our providers experienced prior to telehealth has gone down dramatically since telehealth. So it has forced a wide and much needed adoption of the technology and the way to deliver care that wouldn't have happened otherwise. We've seen our telehealth visits go up over 700% from pre-pandemic to now. I'd say they're now steady state. I mean, of course, they went up a lot higher than that in the early days, but now they're sustained because you've got wide adoption, which is wonderful. Now, I all agree that that's not exactly the best visit that can take place. Certainly, an in-person visit is going to have a better outcome or better impact on the member. But if you're not able to get to the doctor's office or you don't show up, I mean, there's no doubt that a telehealth visit is far, far better than a no-show and a non-visit.
Yeah, and let me just add to that, Beth. What we've seen more specifically with telehealth is that it has created an entirely new outpatient channel for behavioral health specifically. So while we've seen telemedicine increase through the pandemic for all aspects of care, as we return to regular utilization in this period of the pandemic, what we're not seeing is telehealth dropping off for behavioral. So we now have brick and mortar outpatient visits and telemedicine visits for outpatient services. And that seems to be a lasting behavior that we're not seeing in telemedicine over other categories of care. I want to actually dovetail on the point Nate made in his comments regarding integration of behavioral and physical care. We've been talking about that for a decade. We all know that. But we're seeing real meaningful advances in being able to treat a member holistically, their physical health care and their behavioral health care. Telemedicine is, of course, one component of that, but it's a much bigger picture that goes to the fact that we've increased our platform and other data capabilities to include more data holistically around the member to pull a picture and a profile, not only of an entire population, but down to zip codes, down to members. What are the needs at those various levels, both physical and behavioral? One thing we were surprised to learn recently was that 50% of the behavioral diagnoses in our population belong to children between the ages of 5 and 13. That tells us where we have to point our care resources, our outreach activities, our ability to get to those kids. So there's some real numbers and real data that is helping us to truly integrate behavioral health in a way that we've never been able to do very effectively before. I'd also like
Jennifer,
to comment on.
Before you move on from that, I wanted to note that zip code level, what you said about that. I just think that's so critical as we start to really dig below the surface of, and Mary, you said this, great, we're getting to be above average, but if the average is still too low, we've got to raise the whole bar. And so in order to do that, I think we were increasingly learning that we have to get into those subpopulations down to the zip code level. And I love that you're being able to get into the data at that level, because I think that's what it's going to take to start to really move the needle. So I'm sorry to interrupt you. I just wanted to catch that point.
Well, my final point was really about bringing added data capabilities to the value-based arrangements that we're pushing forward on. The agency deserves much credit in moving the state of Florida through the MPIP program to having more providers see higher reimbursement through MPIP. So really what I'm talking about is next gen for us, where we're talking about, within the value-based arrangements we're making, let's stratify those populations. Let's understand understand not only their risk level, which is the normal reference or stratification, but let's stratify them across those measures that you mentioned as being part of the bill in the Florida session now. You know, the age, the sex, the primary language, the ethnicity, race, designated by Social Security, the disability status, for example. If we can bring value-based care to stratified populations more effectively, we're really moving the ball on that whole value delivery as well, which I think goes to something Mary really spoke about very articulately. There's really a crisis still that we need to move away from this volume-based care. But I feel very optimistic that we have some really innovative models that are moving us in that direction, allowing us to not only deliver care with a laser focus, but to measure the care we're giving so that we can actually report out on health outcomes and equity outcomes.
Well, I know we're moving into the last couple of minutes here. So rather than open up another question, maybe just any kind of closing thoughts that you all have or anything you'd like to leave our audience with about Florida, where you think we're going, either challenges or good things. And Nate, you want to jump in?
Yeah, I picked up on something that Mary brought up, and that's the collaboration across organizations. From what I see, I think we operate in too many silos, where we're either people are getting lost in the cracks, or there's a duplication of effort, and there is absolutely a lack of communication. So we focus on trying to produce the partnerships, not only with the provider community, but with the community organizations that can really wrap their arms around our members to help them get where they need to be from a life standpoint. Because once we get them where they need to be from a social welfare standpoint, the barriers to their healthcare are greatly reduced. And so we want to get to a point where we are breaking down those barriers and collaborating with as many organizations and providers as we can, so we're all aligned at making sure that the population is healthier and happy and active. And when they're that way, they're producing happy and active children that are successful and able to get to school. And so there's this cycle that is created when we're all working better together to wrap our arms around these folks who need it most.
Beth, I'm gonna pivot right off of what Nate just said, and I think it is a challenge sometimes with the pace of work and perhaps the focus sometimes in state legislatures, and we've got to think about these children from birth to early childhood development, to their reading level at grade 3, to where they are in middle school, and to achieving that high school diploma, because their health and their interactions with the system are that trajectory that will matter to their successful health outcomes, their independence as adults, successful parents, the great participants in the community. That's what contributes to a robust community, a strong economy. And so we can't just narrowly focus on this one episode. We invest in children in that early intervention and care because of what it means for their future, but it is also the future of our communities and our state. And I think sometimes we're looking for an outcome over a 6-month period of time instead of really understanding what the early commitment of investments need to be in order to achieve that investment over a much longer period of time. And I'll put one more plug in. State agencies have a big role in this. And one of the biggest frustrations, I'm sure, Beth, you share, is the lack of a master client identifier. And I'm going to say this about for children in particular, because children cross over so many state agencies, from Medicaid to DCF to the Department of Education to juvenile justice. And the opportunity to serve those children will come when we can see all of their needs and all of their available resources and how well we're coordinating the delivery of those resources and achieving better outcomes for those children. So I think we've got to continue to push that we get that kind of comprehensive approach from the state and reduce some of those silos.
Yeah, I agree. I know we've got about 30 seconds left. Jennifer, do you want to have any closing comments?
Well, I'm so pleased to have been part of this esteemed panel. I find new inspiration in what everyone has already added today. We're just going to take it back and keep building on the progress we're making. Thank you.
Thank you all for being part of this today. This is, again, it's always great to talk and get the ideas flowing. I hope that the audience has gotten a sense that there are very committed people in Florida working to make our system much better all the time and taking on these big challenges. So thanks for being with us today, and thank you all on the panel.